Good morning and welcome to the CMN Virtual Collaboration Forum. We've got some new faces on the call this morning, which is always great to see. Thank you for joining us bright and early. I'm going to kick us off with some introductions before we get to our speaker for this morning. I would also like to start and take a moment for our land acknowledgement. We would like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory and is a traditional meeting ground and home for many Indigenous peoples. Why are we here this morning? I'm very excited to have this session by Dr. Rob Tanguay. He's going to get into the buprenorphine naloxone recap, some when, why, and how. These are the learning objectives for this session, but I've had a peek at Rob's slides and I think he's gone a little above and beyond. Going to cover lots this morning and we're very grateful he's able to join us. A couple of disclosures. I'd like to introduce Dr. Kathy Scrimshaw, who is our medical lead for the CMN. Kathy?
Oh, hi, I'm Kathy Scrimshaw. I'm a family physician working down south in Pincher Creek, recently retired from clinical work, and I'm a part-time paid employee of the Alberta College of Family Physicians.
Myself, I am Carrie McNabb, and I'm a coordinator for the ACFP. So my disclosure is that I'm a paid employee of the ACFP. And my co-coordinator, who's also here with us this morning, is Agatha Gruchowski. So you also see some emails from her go back and forth. So a couple of disclosures of financial support. We do receive financial support from the ACFP, but we've also received a contribution from the Health Canada Substance Use and Addictions Program. We also receive in-kind support from the ACFP. A couple of CME notes. These collab forum sessions are certified by the CFPC. You get 1 credit per hour. So you will see an attendance survey in the chat log. We can't issue your certificates of attendance unless you fill that out with a complete first name, last name, and email address. So please make sure to do that. Also, just a heads up. So next month, which is going to be March the 18th, our session is going to be AUD in community, evidence and actions. And we're excited to hear from Drs. Kirkwood, Fair, and Mogus. So again, that's going to be another early morning. And just a side note, we've previously sent out Outlook calendar invites for a lot of these, but they've had issues updating if we've ever had to make a change to the link. So we apologize if you get some calendar notifications in your inbox in the next couple of days. We're going to delete those going forward and just go with a good old regular e-blast. And you can sign up and add to calendar if you're interested. So any notes, you can always email us at mentorship@acfp.ca. All right, so evaluations, super important to us. There's one after every session. We've added a little incentive, which is a $25 coffee gift card. Shout out to Nathan Turner, who won last month's evaluation. So without further ado, I'm just going to point that we're going to give it over to Rob for the majority of the session, and I will jump in at the very end with the evaluation and attendance notes. Rob's going to go into his talk. He said he is open to some questions throughout, but probably the majority of them will be answered at the end of his talk. So feel free to comment your questions in the chat as we go along, and I'll make sure to read them as we go and flag any for the Q&A that we want Rob to answer at the end. All right, so at this point, I will turn it over to Rob for his talk. Thank you and good morning, Rob.
Good morning, thank you, and thank you for having me. I'm really excited, and at the same time, I just got to close this up. At the same time, I'm always a little bit nervous about this. Is this coming across full screen?
Looks great.
Perfect. So again, thank you. I think any opportunity to work with the incredible people who are involved in treating and seeing the vast majority of people struggling with addiction is truly an honor. We're gonna go through as much as we can today. I have a lot of slides, so I'll do my best. And I know I'm over-slided, so to speak. So the goal today is to provoke thought and challenge some of the status quo. As a caveat, I am not challenging any specific person or any specific groups. I think this is to challenge us all and to always be thinking and be aware. I really have zero financial interests In the last several years, I have not done any lecture for anybody or sat anywhere doing anything. I have a few grants, of course, and do a bit of independent work, but I'm also the new chief medical officer of a new program opening up that doesn't matter today. As we mentioned, the acknowledgement of the unceded land we're all sitting on in Alberta, and it's an important piece, and thank you for also having that acknowledged earlier. Some learning objectives that we'll go through. So again, to provoke thought and communication around opioid use disorder, along with buprenorphine and naloxone. So we'll talk about home inductions. We'll talk about when we follow up and how to follow up. We'll talk about recovery and deprescribing. And remember, addiction is treated in the community. You are all primary care physicians, or many of you are, as well as some allied health that are here together. But we have to remember much of the innovation in initiating opioid agonist therapy is with our inpatient colleagues. I speak with the St. Paul and VGH group all the time, as well as the St. Mike's group in Toronto, as always trying to steal as much as I can from other people. I also have to let you know I'm home. My kids are getting ready for school. So be ready to hear some screaming in the background, because that is just the way it is. And I'm sure you're all aware of this. So we'll start by talking a little bit about what is addiction. The big question that you got to ask yourself is, can we treat addiction with a prescription pad? I think most people know my answer, but we'll kind of go through this and let you make your own assumption and decision there. 275 million people around the world use drugs of some sort, and approximately 30 million people in this world struggle with addiction of some sort. That was based on 2018, and we have to be really honest in the fact that we have no idea how clear that really is and how good those numbers may be. I would also always like to encourage people to take the Brain Story certification. It's an excellent program done by the Alberta Family Wellness Initiative. Definitely worth doing and checking out, and a good way to try to break down stigma by increasing education. Now, the definition of addiction is huge, and we are certainly not going to read all of this. Keys to remember are the biopsychosocial spiritual aspect of it. And really my favorite way of always thinking about addiction, and when I'm teaching residents and learners and other people, I prefer the 4 C's. So that's that loss of control, the compulsion and craving to use, and continued use despite the consequences of it. Often, if we could just even focus on those 4 C's and we screened using those 4 C's, we'd be better off than no screening at all.
Excuse me, Rob. I'm just going to dive in. Do you know, we're still on your first slide. Have you moved on to show a slide that highlights the brain story?
Totally been moving on.
No, so sorry, Rob. Funny story, I recently took the brain story course. It's actually phenomenal. And someone posted, I will try to find the link and post it in the chat for anyone who's interested in taking that brain story course. Awesome. I can see your slides now. Brain story. Right. There it is.
Anyways, we don't care about this part. So here's our beautiful earth. So brain story, take it. The long definition of addiction, the short definition of addiction. The big question that a lot of people often ask is substance use voluntary? Usually it is voluntary at the beginning, but it's the repeated use that leads to the risks of outcomes of addiction. A lot of the times we use it to feel good, to feel better, to do better. We know stimulants and university students, although we're also seeing a huge jump in a conversation I had yesterday with some Vancouver physicians and UBC students presenting with opioid use disorder. I don't know if they're really doing that to be better, but there's a lot of reasons that we may use curiosity and because others are doing it. We know our social tribe that we hang out with as youth often will dictate how we look upon drug use and how accepting the use of drugs become. So access to the substances is a huge piece as well. But it's that repeated use that really leads to the problems. And it's those susceptible individuals with that repeated use and that access to whatever substance is there that leads to that kind of perfect storm of addiction. Things that we often look at when we're looking at risk factors for addiction, genetics is a big piece, and there's some fascinating data around males and their fathers struggling with alcohol, being incarcerated, and having antisocial personality disorder leads to about a 90% risk that male offspring will also end up with alcohol use disorder. Now, people link that directly to genetics, but we notice the incarceration and the personality disorder intermixing with that. And so we've got to kind of look that there's a lot there, and we almost wonder more about epigenetics. Of course, the way we break down substances and we respond to substances is a huge piece as well. I know many people feel a warmth or euphoria or energy from opioids. I feel nauseous and dizzy. So I am lucky enough not to have that genetic predisposition to enjoy the effect of an opioid, whereas others may have that. And there's many times working in acute pain and talking to people about the effects of the opioids, and many people recognize it of, wow, that was something I really enjoyed, and I don't want any more of that. But there's other pieces that really come into play. So mental health disorders, which also link to genetics, but also our environments and what we're growing up with, emotional and psychological factors, and our ability to regulate our own emotional and psychological factors, and knowing that adverse childhood experiences directly affect neurodevelopment, and that effective neurodevelopment affects our ability to use our executive functioning as well as our HPA axis and our ability to cope with stressors when they hit us. So all of this comes down to childhood in many cases. The classic pyramid of addiction is something that we see where you start with genetic predisposition, then adverse childhood experiences, then that personality development and those coping skills that come with it, emotional dysregulation or the ability to regulate our emotions, high risk and addictive behaviors, including exposure and access. I chuckle about access all the time. I'm curious if anybody wants to jump in and tell me how many barbiturate addiction they're treating right now. My guess is very little. I believe that we have one that I'm aware of that I passed on to a past fellow of mine, thinking this would be a great learning opportunity, and I believe he is still treating said individual. So not an easy process, but something we rarely see anymore because quite simply nobody prescribes barbiturates anymore. So the access is very low. So let's talk about initiating. So we know that addiction is multifactorial. It's a biopsychosocial spiritual approach. We have to understand all aspects. There's no one answer as to how someone gets addicted. Some people, it may be genetics. Some people, it may be related to their mental health. Some people, it just may be bad luck and habitual processes that start getting built up. Everybody's a little bit different. But when we look at opioid use disorder, one of the things that we want to talk about is how do we start the process? Well, some learning objectives here. Are we practicing harm reduction? Are we practicing shared decision making? And are we practicing person-centered care? All of these are important processes, especially at the initiation of a treatment. So when we look at what is harm reduction, it's a public health approach to substance use. It's the 4 pillars of a drug policy, including enforcement and regulation, prevention, harm reduction, and treatment, and they should all be intertwined together. There's lots of examples. We don't need to get there. Of course, the most reducing of the harm is to never inject. But that doesn't mean that using sterile equipment and unused equipment and using that every single time and not sharing your equipment is much safer than sharing, lending, selling, borrowing of equipment. So there are ways that we can do that, and most of you are experts here. Of course, there's the CRISM National Guidelines for Opioid Use Disorder, and one of them is not to detox people off of opioids, especially if there is no any sort of immediate transition to some sort of long-term addiction treatment. So if somebody chooses that they want to detox, that doesn't mean that we absolutely don't do it. It means that we go through a lot of the steps to make sure they're in any sort of right position to be able to do such. Opioid agonist treatment is the so-called gold standard, with buprenorphine naloxone being the preferred option over methadone. Often that's because it's much easier if somebody's not doing well on buprenorphine naloxone to rotate them to methadone than it is to do the opposite. Secondarily to that, we can have much better person-centered care with buprenorphine naloxone. There is zero reason to be doing any sort of witness dosing, any sort of daily dispensing. Individuals can be started at home or at a supervised area, depending on that individual. So there's a lot more person-centered care that can be done with buprenorphine naloxone. And there's tons of evidence of buprenorphine naloxone being done in community clinics. So OBOT has been studied over and over again with primary care leading the way in buprenorphine prescribing. And again, here's just an old article on OBOT from 2003, but really showing that buprenorphine naloxone combination works extremely well in office-based settings with primary care. Now we'll look at some different ways to initiate, but I would really encourage you to take a look at the Canadian Journal of Addictions article on novel methods to support the transition. And this isn't just from methadone, but all full agonist opioids to buprenorphine naloxone. This turns out to continue to be the most downloaded article in the history of the Canadian Journal of Addiction. So check it out. It's open.org. We paid for it to be free. So a great article to look at. And a lot of this is going to come from that article. So we'll start with the obvious, regular induction of buprenorphine naloxone. Now remember, when we're initiating somebody on OAT, we are providing a harm reduction approach. The goal is to provide them with a substance that has less chance of causing an overdose death or harm to that individual. It's not about immediately creating behavioral mechanisms or structuring somebody's life or, getting into psychosocial treatment. None of that stuff matters at all at the initiation. All that matters is building a relationship and working with someone to initiate treatment and hoping that they continue to come back to reduce their risk of death. So everything we're doing at the beginning is about reducing harm. It's not necessarily about treatment. So the initial induction is something that we talk about a lot with patients. We have a home induction protocol that's being put together with Alberta Health Services. So you can look at AHS website to take a look at this. We talk about here for illicit fentanyl, ideally we'd like to see 24 hours without any substance use. I know everybody's thinking right now, and I can already tell, nobody can wait 24 hours. It's not necessarily true, but, I've had some pretty severe opioid use disorder with fentanyl be able to do it. Sometimes we'll do at minimum 12 hours, but it does increase the risk of precipitated withdrawal. But even with that, we've seen precipitated withdrawal at 24 and later. We can use a clinical opioid withdrawal scale above 13 or a subjective opioid withdrawal scale above 16. The idea is a slow initiation, combining concepts of microinduction with traditional inductions. So when I'll never forget sitting with a couple of fellows and watching them try to explain someone how to induce buprenorphine. And they started at 2 milligrams and went to 4 milligrams and waited 4 hours, but maybe 2 hours, then maybe another 4, then maybe 2. And I realized I didn't know what they were talking about. I realized the patient had no idea what was going on. And certainly I did not believe for a second that the fellow had any clue what they were talking about either. So what we tried to do is shift this to a much simplistic form that makes sense for everybody. And that's how we've tried to do it. And so really it's about, and all of this is available on the website, and I'll show you that in a second. It's about just simply dissolving 2 milligrams under the tongue when in moderate to severe withdrawal, or your COWS is greater than 12 or SOWS greater than 17. And really checking every hour. If you are still in withdrawal, take another 2 milligrams, take another 2 milligrams, take another 2 milligrams. In fact, all the way up to 16 milligrams on day 1. And if you have an individual using fentanyl, the chances of being stable on 16 milligrams is pretty low. I know that in speaking again to inpatient colleagues, many are initiating and getting people to 32 milligrams within a few hours on day 1. This is in an inpatient environment. I had one patient that was accidentally given 8 milligram tablets every hour for 4 hours. The patient did fantastic on it. Again, that was actually a medical error, not a treatment algorithm. But I would argue that in a matter of no time, we'll start to see some of these algorithms come out where it will be in moderate to severe withdrawal, 8 milligrams every hour for 4 hours, and you'll have someone stable in 4 hours on 32 milligrams. This is way off label, just to be very clear. Although there is no specific initiation guideline, the algorithm that's put in place by Indivior in the monograph is a suggestion, and they're very clear about that in the monograph. So a lot of what we've done has been confusing. And so when we sit with a patient, we just tell them, you're going to take 1 pill every hour till you feel good. You're going to do that for 8 hours on day 1 and up to 8 hours on day 2. Simple as that. You take your total dose on day 1 and take it at the beginning of day 2, and then 1 pill every hour till you feel good. The vast majority of people that we see are on 32 or higher. I've had patients as high as in the 40s in order to stabilize their fentanyl tolerance and dependence, which because of the high affinity of fentanyl, we need much higher doses than what was studied in the literature. Remember, the 24 milligrams was based on 2 points of intranasal heroin or diacetylmorphine. And hence, it really doesn't relate to almost any of the patients I ever see.
Rob?
Yep.
Yeah, there's a question here in the chat.
Sure.
They were
Sorry,
asking about a situation where individuals are unable to manage the pacing of dosing. They just take all the 2 milligram tablets right at once. Is there anything to assess for this method versus an inpatient?
So you have somebody who simply isn't able to take 1 pill every hour. Is that the question?
Yeah, I think it's okay. Ricky. I think that's the
yeah. I mean,
question.
You know, inpatient sometimes is ideal. An office setting and having them come in may be ideal. There's microdosing, which we'll get into, maybe ideal, where they just take a new dose every day and increase slowly over time. A Butrans patch may be ideal. Obviously, a lot of what we're going to be talking about, sometimes it's going to work for some people and sometimes it's not going to work for some people. So I hope I answered that. There is no algorithm or protocol for taking it all at once by initiation that I'm aware of. But I would say that will be coming sooner rather than later. Are there any other questions?
I think I don't see anything in the chat.
Okay. So I would encourage everybody, check out the paces. There's all of the home induction protocol of 1 pill every hour till you feel good. 8 hours day 1, total dose from day 1, or 16 milligrams in the morning. So usually I write it as 2 8 milligram tablets and 16 2 milligram tablets for 2 days. And I always call on day 2 to find out where they got stabilized on. Some people will stabilize at 24, 20 milligrams. Many people need more than the 32. If we don't call them on day 2 to find out what's going on for them and where they're sitting, how are we going to know if they're stabilized? If we wait an entire week and they end up not stabilizing and then end up going back to using, which of course, why wouldn't they do that? They're not going to just sit there and be sick. Then we claim that they failed Suboxone. Well, did they or did we fail them? And so we always make sure we call on day 2. I always find out what dose they got to or any complications that may have led to their dosing. Having a good team is really important, and having good nurses that can make those phone calls or a good team. The addiction counselors and often the recovery coaches are excellent in this area too. So a good team is a really important process. Okay. So again, check out the quick reference on the PACES training site, and there is the home induction tab in the quick reference. There are videos for patients when they go home, and there's another piece. So these are videos that are designed that we put together that walk a patient through everything I just finished talking about. taking one pill every hour for 8 hours. Take your total dose from day one, which is 16 milligrams for most people, and then take one pill every hour for 8 hours. And so all of that is laid out into videos. It goes through how to assess your withdrawal symptoms. It goes through any red flags to be aware of. It tells you when to call your practitioner. These are excellent videos that are being used in BC, Ontario, and other places around the country. Please check it out and use it with your patient. They don't need to be coached in your clinic on a plastic chair in severe withdrawal. I wouldn't want anyone to go through that process. They can do it from home or from somewhere that they're more comfortable in doing it. Of course, if they want to do it in your office, you should have that option as well. For chronic pain, this is the ideal way of doing things. Almost every chronic pain patient that I end up treating with addiction has run out of their prescription before, knows what it's like to go 12 hours without any medication, can often take their last dose at night, which is usually, 8, 9 o'clock at night, go to bed, and then they start their Suboxone at, and I'm sorry, I should say buprenorphine naloxone. They start that at, 12 hours later, 8 or 9 in the morning. And so most people can do very well with this. We published on this protocol. Again, it goes to 24 for chronic pain, mostly because unless they're on really high doses, most people will stabilize at 16 to 24 milligrams on prescribed opioids. And they are much different than what we see with the high tolerance that we're seeing today with individuals using fentanyl. So check that one out as well. It's also open access. So again, the classic induction should be considered a home induction, 2 milligrams every hour for 8 hours. Day 2, the total of that dose plus 2 milligrams every hour for up to 8 hours. For those people who just cannot stop the fentanyl or cannot do it, we'll talk about all the different bridging techniques that we have. So the microinduction method is a really important method. Many of you are experts in this method. And for those who are waiting to see, oh, good, he's going to have an algorithm for us, I probably won't, because there is no specific algorithm. It's important to remember fentanyl is a really different opioid than many of the other opioids. Part of it is its lipophilic aspect. So it will sit inside of our fat cells in our body for a lot longer than most other opioids. A lot of people believe that fentanyl is fast acting, so it's in and out in an hour or two. That's not true. Its half-life is similar to that of morphine, and we often label it at about 4 hours. So it does have a longer half-life than most people expected, but it does have fast in, fast out from the blood-brain barrier. So it seems to get into the brain quickly, and it seems to leave fairly quickly when it does hit that half-life and come down quickly. This is a graph that I didn't reference, and I apologize. I realize looking at it right now, but out of a really interesting study looking at fentanyl's half-life, and it's fascinating that 4 hours after injection, your fentanyl level in your fat is the same as when you injected it in the first place. So it's really quite fascinating to see how long it stays in the fat and how long it's staying in muscle and plasma. And this is why we really want people to try to maintain abstinence for as long as possible, or use techniques to wash out the fentanyl and keep them stable on something else before initiating buprenorphine naloxone. And really in the precipitated withdrawal events that I've had, and I know we've probably all had one or two or many, it's often illicit fentanyl or the patch fentanyl, where I've had a couple on that as well. And again, it talks about the molecule itself. So how does bridging work? What is the concept of what we're trying to do? And really the idea is just a simple titration and taper happening at the same time, where we're slowly tapering the full agonist and we're titrating the buprenorphine. And again, these are really simple processes that instead of just removing the full agonist and putting a partial agonist in, which is going to cause precipitated withdrawal, we just want to slowly chip away at those receptors and replace a full agonist with a partial agonist a little bit at a time, so that the individual actually feels next to nothing. Now, they're not going to feel great. And you can see on day 2 and day 3, her facial features suggest she's not feeling fantastic. But again, if we extend the length of the microdosing, many people feel next to nothing. Now, of course, an ode to the Bernese method. This was initially a poster abstract from a conference in Europe, and then was published a little bit after that. Many of us had kind of copied that poster and just tried different techniques of doing such. This is one of the ones that we see often used, which is simply a quarter tablet for day 1 and day 2, half a tablet often for day 3 and day 4, full tablet day 5 and day 6, and then we start increasing up to a tablet and a half, 2 tablets, and then we start going up from there. Often we're at about day 9 or 10. As we're titrating up is when we'll stop their full agonist, whatever they're using, and then we'll do a fairly rapid titration at that time, again taking 2 milligrams every hour. So if they get to 16, we might just get them to stop at that time and then increase up to 24 to 32 at that time, or whatever dose we need to for them to be no longer ill and to be stabilized. So look, everybody's got a different Bernese method or a different micro dosing. So, this is where relying on your mentors and mentors who are watching, I hope you have one that you've used and felt good with. Some of my colleagues who work with elderly patients who are on fentanyl patches often have kind of these 2 to 4 week micro inductions where they go really, really slow, and that overlap lasts for a long time. Everybody's got a different method, so there is no right method here. And unfortunately, there's not a lot of rigor and research into a specific type of method. The Butrans patch, this is a fantastic method, and anybody who's used it knows it works really well. Unfortunately, it's not covered, and that's really the biggest problem with it. There's the 7-day and 14-day and 4-day methods. The 7-day is really simple. You throw on a 5 microgram patch, then you throw on a 10 microgram patch, and so here that's not true. These are just looking at the doses. So we throw 2 20s on. Sometimes I even throw on just 120. Some people wait for a urine drug screen to be positive for buprenorphine. I've never actually used the urine drug screen process. That's part of a research protocol that we've got in place under Dr. Ghosh. But we're able to, after approximately 3 to 6 days, stop whatever they're taking and start buprenorphine induction after a 1 milligram buprenorphine experiment. So if you give them 1 milligram and they don't go into any sort of severe withdrawal, you can start the induction method. Again, higher doses of methadone or higher doses of fentanyl use may require the slowest possible induction that you can. And that patch can be worn up to a week. So don't forget, it can also be worn on the day of induction. The 4-day protocol is a little bit more aggressive. 1 patch on day 1, 2 patches on day 2, 3 patches on day 3. On day 4, you just stop whatever opioid you're using, and you're not going to go into the severe withdrawal because you've already replaced some of those receptors. And so people feel a little bit better, and you can initiate directly from that day 4 onto that home induction protocol of 2 milligrams every hour till you feel good. So this is a really nice method. I know many of you have probably used it. It works well in the inpatient environment. I've used it many a times. We've used it in pregnancy. Works really well in pregnancy as well. Again, on the inpatient environment, we don't have to worry about coverage, and it works a little bit better that way. But that's really the biggest problem with this protocol, is that those patches are expensive, and haven't figured out how to get those covered. There is the 7-day protocol as well. So 1 patch on day 1, 2 patches on day 3, 3 patches on day 5, and then day 7, they start their home induction. So again, here's your 3-day. So day 1, and these slides will be available for everyone. So day 1, day 2, day 3, 1, 2, and 3, 20 microgram patches. Patches come off. They initiate the 2 milligrams every hour till they feel good. Same thing with the 7-day, day 1, day 3, day 5, and then on day 7, they take the patches off and they initiate their home induction. So there is the SROM strategy as well. We published on this back in 2019, which seems like an eternity ago right now. And this is really something that many people have been using and used for a long time. The concept of what we really believed is that, again, we want to wash out the methadone or wash out the fentanyl to reduce the risk of precipitated withdrawal by rotating them over to slow release oral morphine. Rotating from morphine or the Cadian doses that we use over to buprenorphine naloxone is like the easiest thing. They basically just start their home induction when they normally take their Cadian dose. The protocol we put together was 200 milligrams on day 1, and then increasing as much as 50 to 100 milligrams a day on day 2 and day 3 until they're stable. Some people need massive doses, and I understand that. And this is the importance of having inpatient providers and colleagues, where ideally we would have inpatient beds in every city that we live in, but we don't. We don't have any in Calgary. So this is sometimes the ideal need is using SROM in an outpatient program where you're rapidly titrating as best as possible. And it doesn't have to be as aggressive as day 2 and day 3. It may take a few weeks to stabilize them on SROM. Once you have them stabilized, rotating to buprenorphine naloxone is a walk in the park. It's go back to the easy first protocol we had where they do their home induction, and when they normally take their Cadian, they just start their Suboxone. The advantage of this is the Cadian a lot of people like. We have seen anecdotally, no research behind this, but we've seen a few more overdoses on Cadian than we would see on Suboxone or buprenorphine naloxone. It doesn't seem to be quite as protective as what we see in the buprenorphine or the methadone individuals. But again, that's anecdotal based on very low numbers that we just kind of went through in an unfortunate exercise at our clinic. Again, the advantage of the morphine is it'll easily help wash out the fentanyl or methadone that we're trying to replace, and allows for stabilization. When we switch to buprenorphine naloxone, they can immediately get weak carries. Many of the times I give 1 month at a time, depending on the individual, so that they start to get some independence, which is important. We start working on person-centered care. They don't need to be in the pharmacy every minute of every day. I had an unfortunate run-in with a pharmacy in Southern Alberta recently that because the patient didn't pick up the prescription on the day I wrote it, they canceled it. So when she showed up a few days later, they refused to give it to her. These kind of archaic practices are barbaric and need to stop. Often I'll talk to the pharmacy. I've had prescriptions sitting for a month or 2 as I'm still working with the individual to even think about starting the process. But let them know it's there. Whenever you want to go get it, you can go get it. And these are the important things we should be doing. So again, that SROM transition approach is methadone or whatever full agonist opioid they're on, including fentanyl, rotate them over to Cadian and get them stabilized. Then that rotation to buprenorphine is really, really easy. And again, the reason for this is we're supposed to be daily dispensing with witnessed any Cadian as it is highly diverted and has some value to it. So we don't want it to be diverted too much, although it's probably safer than the crap we have on the street. So is it really that bad? Anyways, we're not going to get into that right now. But then we can easily rotate to buprenorphine and not worry about daily dispensing or witnessing as it doesn't improve outcomes. In fact, daily witnessing increases costs and reduces overall outcomes of retention in comparison to weekly carries and home inductions. So that was all about induction and initiation. And there is a really good paper that it can give you all of that information. It's all in there. But that is not treating opioid addiction. That is the harm reduction approach of getting someone on a less harmful substance that really may not be harmful at all for many people. The treating part gets a little bit different. Is a prescription enough? What about their mental health? What about their psychosocial functioning? What about housing? What about all the other wraparound services? Often on that pyramid, when we look at treatment, we focus on kind of those two middle pieces, and that's kind of coping skills and giving people skills and teaching people how to regulate their emotions and regulate their urges and cravings and dealing with all the addiction counseling piece as well. Remember, everybody has a toolbox of skills, of coping skills. Some people have more than others, but we all have some sort of toolbox. Often what we see in addiction is that there are no coping skills left by the time they get to me often. And all that's left is using substances to cope. And a lot of that has to do with the withdrawal effect. During withdrawal, it's very hard to use any skills during withdrawal to cope with the emotions and everything that's going on. Now, what we often do is we ask someone to stop using whatever substance they're using. They got to detox, they got to clean up, all of these kind of stigmatizing processes that we do, except their toolbox is empty. Then they're going to have distress in their life. And that distress is going to lead to, oh my God, what do I do? How do I cope with this? Everybody's telling them, don't use, don't use, don't use. Their shame and their guilt starts going up because they don't know how to cope. Their toolbox is empty because we just detoxed them. And they unfortunately go back to what they know best, something that's helped them and worked with them. And so this kind of perpetuation of detox and relapse and detox and relapse is a lot of the problems that we have in the treatment of addiction. And so the thing that's missing there is the treatment part. And that's an important process. This is about the therapeutic process, the biopsychosocial spiritual approach. This is about developing skills, about teaching people how to emotionally regulate, especially with opioids. I mean, opioids nullify a lot of our emotions. And when we even rotate from full agonist over to buprenorphine, the partial agonist, people notice a big flood of emotions. And if you're not spending some time reminding them that, yes, you might notice a lot more emotions, and that's okay. We have a team here that's going to help you through that. This is where DBT skill sets are really important in teaching that emotion regulation. We want to put tools back in the toolbox. We love to fill it up, and that's always the ideal, but it's not always the case. So the key is always making sure we're treating with some addiction counseling, we're rebuilding skills, we're teaching emotion regulation, and then we're also identifying and looking at the mental health processes, and we mustn't forget about that. And what about ending treatment? There's and I've talked to CCSA and CSAM and everybody across the country. There really is nothing that teaches us about when is treatment done. I almost feel like it's taboo to talk about it. So we'll talk a bit about when do we taper and why do we taper. It's important processes to remember. We never taper if somebody's not ready. And people aren't ready if they're still using, if they're still struggling around individuals who are using, if they're struggling with mental health, if they don't have the coping skills to deal with urges. There's so much to the assessment to determine it. But remember, when we look at resiliency, it's an important piece. Negative early childhood experiences make us less resilient. Positive supports can balance out that resiliency. And that's got to be the case, is that we build resilience, and we do so with skills, with love, and with support. And that's what resilience comes from. And remember, resilience isn't about being the blow up clown doll that just keeps getting up and every time it can take a punch. That is not what resilience is. It's not the ability to take the punch. It's the ability to see the punch coming. It's the ability to avoid the punch. And when you do it's the ability to absorb and build capacity to adapt to that punch. So this is where recovery capital really becomes important, because recovery capital is building resiliency. And there's so many things. Are they financially starting to build some capital? Are they, politically, I don't really like, but socially, are they connected to people? Are they building relationships? Are they getting involved in their community? Are they building even simple things? Do they have a hobby? Do they have relationships with people who aren't using? These really building these healthy ecosystems in that social, personal, and collective aspect of their recovery. Now, remember, a big piece of this is psychiatric treatment. We have to make sure that we're including psychosocial aspects to our opioid dependency treatment. Now, remember, This article that came out in 2011, 10 years ago, this Cochrane review suggested that intense psychosocial treatment doesn't make any difference in outcome, except they never actually assessed intense psychosocial. In fact, it should be noted the control intervention used in the studies included in the review on maintenance treatments is a program that routinely offers counseling sessions in addition to methadone. Thus, the review actually did not evaluate the question of whether ancillary psychosocial interventions is needed when methadone maintenance is provided. Anytime you've ever seen this article quoted suggesting that we don't need psychosocial, just remind yourself the article never actually assessed it, and that individuals who were in the control group were getting counseling sessions. And that piece is extremely important. And of course, since then, there's been many, many studies showing the benefit of adjunct personalized psychosocial intervention. This is one of the better ones in the Lancet. And this study actually looked at those who were failing opioid agonist therapy and adding personalized psychosocial intervention and therapy. And they did much better by adding that personalized therapy in. And we mustn't forget how much PTSD we see in our patients. Now, I often talk about PTSD as being like the Rubik's Cube of diagnoses. I would almost just, if somebody tells you they've had a traumatizing experience, but it doesn't quite meet criteria A, you know, that someone almost died or they almost died or they are sexually violated in a really violent way, that doesn't mean anything. Somebody's experience to what happened to them and their inability to move on from it. And addiction in itself perpetuates trauma. I was speaking with a colleague yesterday about an inpatient and just the amount of traumas that people go through. We must assess for PTSD, and we must have access to evidence-based trauma therapy. This isn't just about being trauma-informed and preventing them from becoming triggered in your clinic, because they'll go to the 7-Eleven and get triggered, or the Safeway and get triggered, or the shelter and get triggered. They're going to get triggered somewhere. We should be looking at how to treat that aspect. And of course, NAAA, these peer-related groups, in and of themselves are not evidence-based, but in adjunct to treatment, significantly improve outcomes of recovery and reduction in relapse. And so please don't forget to include these. And it doesn't have to be an A, it can also be Smart Recovery. There's the, and I don't remember the name of it now, of course, but there's a really good one that goes on in a Buddhist temple here in Calgary, and they're scattered amongst the country. They take a spiritual approach, but not really a kind of a Judeo-Christian approach that we see in AA, but get them to connect to something. If I can get someone to go into AA, I assess every time with somebody their religiosity. Are they willing to go to anything that's kind of religious? We do have to remember we grew up or we're working and living in Alberta, and people who grew up here often grew up in a church. This is the Bible Belt of our country. So feel free to ask and to probe into that. And then we can move into how do we taper. Remember, we never taper without consent. That's the most important thing. Deprescribing is something we do with someone. Tapering is something that we do to someone. So we deprescribe and we work with the individual. Always assess for addiction and mental health if somebody's continuing to use or around people using, or their mental health is untreated. Tapering might not be the best idea, or deprescribing. Assess their recovery capital, do it with consent, go slow. There's no algorithm, take your time. The advantage with buprenorphine naloxone is we can start tapering almost immediately, usually after about 8 to 12 weeks of stabilization. The partial agonist starts to see receptor changes, and we can start tapering immediately. Most people will feel nothing until around that 16 to 12 milligrams, and then they'll notice it. But you'll find you can easily taper from 30 to 40 milligrams, whatever you're stabilizing on, down to 12 to 16 milligrams, regardless of all this other piece, because it's still highly protective at 16 milligrams. So we are often tapering basically everyone after high dose initiation. And it's a simple process, but we're still always looking for craving, any signs of relapse, and listening to the individual, just like how we increase the dose. People should not feel withdrawal symptoms at the initiation of taper. This should be really slow, really easy, and not overwhelming for somebody. And when we do get into that withdrawal symptoms, that's a big risk factor for craving and relapse. So somebody better have gone through a lot of treatment and stabilization. So our patients, we'd like them to go to DBT skill set and do trauma therapy prior, as well as a relapse prevention group prior to tapering off. Again, there's some really cool clinical pearls, such as a Butrans patch at the end. So often we go from 2 milligrams and then we rotate from 2 to 1. So a full tab and a half tab every other day. Then we go down to the 1 microgram. But that 1 microgram, if they have any sort of coverage or any sort of funding, or maybe you have a pretty interesting research protocol, the Butrans patch, 220s, 120, a 15, a 10, a 5, a really nice slow taper over several weeks to months. And most people feel nothing. Now, if they don't have coverage, a really good pharmacist can kind of create these doses for you. I've had patients try cutting these things. They're tiny, they're hard, they shatter, and people are doing it, but it's easier if you can get a good pharmacist to do it. Then, of course, using medications for the detox will be important. So when we look at what is treatment and what is recovery, remember, treatment always starts at harm reduction, no matter what we're doing, whether it's IOT, whether it's providing sterilized equipment, all the way to getting into the actual treatment process, all the way to this idea of recovering from addiction. Now, recovery can be very personalized. You might be recovering from homelessness. You might be recovering from the sex trade. But when it comes to addiction, recovery is no longer meeting the DSM diagnosis of a substance use disorder. Pretty simple. Let's not make it complicated. That is what recovery from addiction is. And so people can be recovered on methadone, on buprenorphine, naloxone, on Kadian, on IOT, if they are no longer struggling with all the aspects of addiction itself. Now, of course, if you want to learn more, I always encourage you to join. This is my shameless plug, the Alberta Addiction Education Sessions. And you can go to ahs.ca/CD series and see all of the previously recorded ones with experts from all over the country supporting us through this process. And I love to always finish with this quote: imagine a world where it's easier to get help than to get high. We are not in that world today, but we are getting there. And I'll pause there or stop there, and happy to take questions and kind of go from there. And I know that was a real whirlwind and we flew through stuff, but I think hopefully a Q&A would be easier to do.
That was amazing. Thank you so much, Rob. You are really a master at fitting a lot of information into a limited amount of time.
One would say a master of speaking fast.
And do you know what? Clearly, though, if it were me, I would be tripping over my words and, you would not get it out. But I actually just copy and pasted the questions that came throughout the session into one comment. And I kind of just listed the person's name and the order at which they came. So the first one was Mary. And I think it was when you were talking about midway through the session, she says, does obesity cause additional risk?
It's I have tried really hard to try to understand, what independent variables increase risk of having that kind of precipitated withdrawal, or even, who's going to respond to buprenorphine and who's going to have an adverse reaction to buprenorphine. I don't know the answer as to whether obesity causes additional risk, but anecdotally, I have not seen that. But I'd be happy to hear from anyone else. There's a lot of experts here today that do this as much, if not more, than I do. But I have not seen any literature that suggests that it is a risk factor. I get it, because the fentanyl storing in the adipose tissue, it makes sense. But it's still storing in the muscle tissue and everywhere else. So it seems that when you go into withdrawal, the body's natural response is to release it. And that seems to be part of the process.
So Rob, the next question was about the percentage of people that may have adverse reactions, allergy, they don't itchy, all those things. Do you have any sort of gut feeling on that?
I use a lot in kind of pain. And so I get to see lots of different responses to individuals who have that overlap of pain and addiction. as well as individuals who are using fentanyl over at our RAM clinic. I don't know the exact number, and I apologize. And you know, I haven't done anything with Indivior for many, many years. I am not sure what percentage have it, but some people get it, and some people just do not respond well to buprenorphine. They do not feel well. Some people, even though it's actually got an actual study showing its antidepressant effect, some people get really depressed on it. Some people feel really terrible on it. Sometimes I wonder if it's just leaving that full agonist and some of the addictive features, and even addictive, is that the right word? Some people feel better on opioids. So, you know, is that a bad thing that we're rotating them to a partial agonist and they start feeling worse? I again cannot determine who it's going to be. I'd like to believe I think I know it, and I usually make a guess before it's going to happen. And some people just, they either do amazing and I thought they were going to do horrible, or they do horrible and I thought, man, I thought you were the perfect person for it. Again, I'd rely on a lot of expertise here if they're interested in piping in, but I don't know the answer, and I do know it happens.
Yeah, exactly. Oh. So there's two, actually multiple questions talking about access to training. So Bill Hendricks, I think up in Central Zone, is wondering, DBT is an important aspect of therapy. How do you develop the skills? And Kayla was also wondering about resources, access to trauma therapy for patients with PTSD. And yeah. And the other question we have is, the PACES course is behind the firewall on AHS.
No,
so if you don't have an
no,
AHS,
it's not.
is it
It's
open
not.
now? Okay.
It's always been open. It has never, ever been behind a firewall. It has
Okay.
always been accessible for anyone to use, and we made sure of that.
Okay. So we'll post that on our resource center.
For sure.
Yeah. Because that has been a question that came up, and we did have difficulty accessing it. So I don't know why, but I can get the link anyway. So
Should be no
fill
problem.
that
It's
in.
also free at U of C, so you can go to U of C and take it there as well.
Yeah.
So it is absolutely no firewall. Same thing with the CD series, no firewalls. This is designed for people to also get access to their videos, which is on the PACES website. No firewalls.
Yeah, I wonder
So
why
I have
that's
patients
happening.
using it all the time.
Yeah, that sounds great. We'll put that up. But any comment on trauma-informed care, DPT training?
Yeah, so it's a great question. I mean, the best team is Behavioral Tech, which is Marsha Linehan's group out of Washington. Obviously, that's the best place to try to get your training. You know, Bill, you're up in Cars Cost Less in Wetaskiwin, and so I know that. Sorry, I always think of that when I hear the word. I know that it's there may not be a DBT group program there. You might have to connect with the Edmonton DBT group. What we're trying to do with our fellows is making sure that they go in and they do their DBT skills training with our DBT group in Calgary under the Department of Psychiatry. And, you know, the fellows who've done it have really enjoyed it. So I think it's a really important piece. Often what I tell people when you're looking for this kind of stuff is just to Google it. The trauma part, look, you know, you can take lots of different trauma training, EMDR training, accelerated resolution therapy training, prolonged exposure, which is really heavy. And there's a lot of vicarious trauma that can occur with that. So I don't recommend it unless you're working in a group where people can kind of really support you through that process. But ART, I mean, Colleen Clark is the national trainer and works here in Calgary at OSI. So that is fully available. They train every month. And so every month is a training. So just Google Accelerated Resolution Training Calgary. That's ART, Accelerated Resolution Therapy. You can Google that and do that training right here. And so I know that I hear this all the time from primary care. I don't have the resources you have, except people don't realize I don't have the resources either. And so the idea is to get good at some of this yourself. You don't have to be a DBT therapist, but doing DBT group isn't that hard to learn to do. And you don't have to be the best trauma therapist, but being able to add a little bit of trauma therapy into your practice. I mean, look, I call ART fairy dust. It can be really impressive, the responses people get. We've seen some excellent outcomes at ODP before we lost our psychologist. There's no question it makes a huge difference in people's lives. And I have not met very many people struggling with opioid use disorder that don't have some sort of trauma, especially by the time they get to us. And I agree with Lucas, motivational interviewing, if you're prescribing, you should take a course in this. It's really just about being nice to people. I mean, harm reduction and being nice to people and focusing on the person is all based on motivational interviewing, which is roll with the punches, listen to people, don't challenge people, and work with them to move towards a place by asking them open-ended questions. It's been around a long, long time, and you should definitely take the course. It's easy.
I don't know if you see the question from Jess there.
Okay, hold on.
Just above where Lucas talked about it. It's talking about the direct work you've done with the provincial government regarding supervised consumption. Yeah. How do you remain positive with our current government? When our current government is actively defunding IOT and threatening to close the SCS.
Well, how does any of us stay positive with it? I mean, look, it's impossible to answer that question. It's a horrific time, and all I care about is doing my best with my patients. And I did an article with the Globe and Mail about IOT. I offered to be an expert witness if they needed during their trial. What do you do? I mean, we know IOT works. Was IOT set up with a lot of positives? Absolutely. Do people do well with it? Absolutely. I wish I had better answers for everyone, but I don't.
Okay, thanks.
Sorry.
And then there was a last question, just commenting on chronic pain patients and use of Suboxone and overcoming the resistance. It's sort of, can you comment on that? I think is what the question there.
Sorry, so chronic over. Oh yeah. So it's a good question. Look, when anybody is working with me, they all go through a bit of a PowerPoint presentation about what we do at our clinic. And then in that, we talk about how buprenorphine may be extremely beneficial, especially for those with opioid-induced hyperalgesia. Buprenorphine is the only treatment outside of IV ketamine, which we don't have access to, so that's out the window, and IV buprenorphine, which also is not accessible. So it's one of 3 treatments we have for opioid-induced hyperalgesia. The other part is that I always remind people pretty simply, in a shared decision-making process, we're going to try it. Let's see what happens. I have some people who, their pain massively improves, their quality of life improves, their emotions improve, everything improves. And if that's for you, that's great. And if everything gets worse for you, we'll put you right back where we started again. In fact, we can actually go to lower dose because some of the tolerance will come down during the trial. So that's the answer, is let them know there's always a back door. No matter what happens, I will put you back onto your opioid medications, and we'll work on stabilizing that. Even moderate opioid use disorder with chronic pain, we can rebuild some of that control again. I do this all the time. It's just a matter of having a really strong team with you and working through those kind of emotional pieces, bringing the prescribing down to sometimes people who are really struggling with control to daily, and find out where that control loss is. Are they actually hyper tolerant and hence in lots of pain? Rotate them, drop the 25%. So just rotate them directly using a conversion table. Often that 25% increase from the rotation by not using the cross tolerance taper will improve their pain outcomes. And so find out, are they just really tolerant and they're actually in lots of pain? And if so, you can stabilize that pain with the opioid, and then you can start chipping away at it slowly once it's stabilized. But don't taper someone off of chronic opioid therapy if they're in lots of pain. It's going to be a disaster. Rotate them. Often this is where buprenorphine is really beneficial, is when I have someone in high pain on high opioids. It may not be hyperalgesia, it may just be tolerance, but rotating them over to buprenorphine, often people do really, really well. And if they don't want to, or don't, do well, then I'll rotate them to a different opioid, sometimes from morphine to oxycodone or to hydromorphone or whatever the case may be. And that rotation in itself can help people. That was a very long answer. I apologize. And there was one more about skin reaction. Interestingly, I find the puffers work the best. So you can spray the steroid puffer on the skin. After you've applied the patch, you can kind of spray it around the patch. Sometimes you can spray it twice before you put the patch on, let it dry a bit. You can even use some sort of steroid cream, whatever. But again, be careful. It's got to be fully dry before you put that patch on. But often we'll put the patch on, then we'll spray it afterwards, and it can make a huge difference for people. So we do treat some of those reactions with just the steroid asthma puffers. And Luke has mentioned, I find it depends on the patient, but that many with fibromyalgia type pain do better on buprenorphine than methadone. Oh, 100% agree with that, Lucas. Like, I mean, I see some people, I've seen people's pain almost completely go away by rotating them over. People do really well, but again, they have to know there's a back door. They can't be forced into it. It has to be shared decision. It has to be person-centered. Because if they go in with any sort of belief that you're going to try to hurt them or harm them, or you're not doing it with them, it doesn't matter how good it is, they're not going to like it.
That's great. Well, I know we're a little bit over time. Really appreciate everybody hanging in there till the end. And thank you so much, Rob, for the wealth of information. The slides will be available. We'll be sending those out. We'll also put all the links to PACES, all the different training programs for DBT, trauma-informed care. So we'll pull all that together and send it out, and we'll also post it on the discussion board.
Sure.
Yeah.
And don't forget actual trauma therapy. Trauma-informed care is really good when they're in the clinic, but it doesn't help anyone when they leave.